Jasim, we're going to make a start. We've got the participants from India as well. So I'm going to give you an introduction. Is that okay?
Sure.
So I would like to start the session today by introducing Dr. Jasim Shihab. Dr. Jasim Shihab is a consultant neonatologist who currently works in East Lancashire NHS Trust. And he has a special interest in neonatal ethics, having a lot of experience of having managed babies at extremes of viability in a very busy neonatal unit where there is quite a multicultural population. He clearly has a huge amount of experience in that regard and has previously given and run workshops on medical futility and how we manage that in circumstances where there might be religious disagreement with the family. Jasim has been working in pediatrics and neonatology for nearly 20 years now, and we've been colleagues together in India. So it's an absolute pleasure to have him here with us today, talking to us. Just for the participants, once again, you're muted on entry. Jasim will be talking, and any questions you have should be put through the chat, please, for him to answer right at the end. Thank you. Jasim, I'm going to hand over to you and mute myself.
Thank you, Alok, for the kind introduction. Are you able to hear me loud and clear?
Yes, I can hear you.
All right. Okay. Hello, participants. This talk, when I've given it before or similar talks before, is generally a very interactive live session. And I put in some humor in these sessions and try to make what is a difficult topic easy and humorous. But I'm going to give it a try online for the first time, the same topic. Let's see how it goes, and you can give me your feedback on what you feel and how I should change, if I should change at all when I give this talk again. Right. So thank you, Alok, for the introduction. I'm Jasim. Friends call me Jasim, and I've been working in the UK for quite some time now. Previously, I was a consultant in India as well, and have faced ethical problems in different scenarios and situations, and have dealt with multicultural in multicultural settings. I have worked in different states in India and different parts of the UK as well. Previously with the Royal London Hospital, again, which caters to a wide range of multicultural secular society. And where I work currently in East Lancashire, we have wide multicultural religious people of many faiths who come and deliver here, and we look after the neonates. So with that, I will start. So how I'll go about this talk is that I'll talk about one patient scenario and take you through that scenario. And then we'll talk about futility, what is futility, and then about how religious interplay occurs in end-of-life care decisions. And then in the end, I'll talk to you about how we have created a framework in our setting in East Lancashire on how to go about such cases as well. And then we can have a panel discussion at the end, if that's all right. So patient X. So this was a baby who was 7 months and 54 weeks corrected, and parents were refusing withdrawal of care. That's the gist. So essentially, it was a 26-week-old 920 gramma PROM, was a clomid-assisted precious pregnancy born to West African Nigerian parents who had recently arrived in the United Kingdom. So clinical course, in the first 4 weeks, the baby had initially severe RDS, needing surfactant, high frequency ventilation, nitric oxide, and antibiotics. Also had a large PDA, which didn't work with medical management and had to go for a PDA ligation. And after that, the baby developed ventilator-associated pneumonia, went on to antibiotics, then steroids were tried, and the baby was extubated for 3 weeks on bubble CPAP. But at 8 weeks, the lungs condition worsened and was reintubated. Uh, Around 12 weeks of life, the chronic lung disease workup was initiated. TORCH and CMV were negative, CF was negative, and the TFTs were normal. So a term charactered a diagnosis of chronic lung disease, which was severe, was made. The echo had showed pulmonary arterial hypertension. Sildenafil was started. Further course of steroids were given, and then the baby was extubated to CPAP. Both non-invasive ventilation BiPAP and CPAP were tried. A baby couldn't cope and had to be reintubated again. Investigations were sent for surfactant deficiency as well. At 44 weeks, corrected discussions were initiated with parents. Baby was in a high ventilatory setting of around 100% with nitric oxide on board. Baby was on sildenafil, diuretics, and the medical team had come to the conclusion that they could not offer anything more. Now, their medical team's priority was to keep the baby comfortable. There was difficulties caring. The nursing staff were finding it emotionally difficult to continue caring for the baby, and they felt that we were prolonging the inevitable. But the parents wanted to continue all intensive care based on their religious beliefs. And that's when the conflict arose. Parents accused the medical team of wanting to let the baby die. Parents felt that a miracle will cure him. All right, so keep this case in the back of your mind, and then we'll go about a discussion of futility, and then we'll reanalyze it at the end of the talk. So what is medical futility? And this was an abstract presented at one of the pediatrics conferences, where a survey was sent out to all staff in a unit asking what they think was the actual definition of futility. And you can see that there's a wide variety of definitions which have been mentioned over here. People have said treatment doesn't lead to meaningful life or quality of life. Treatment will not prevent death or prolong life. Treatment will not change patient's outcome. Treatment leads to pain and suffering. Now, this is both the medical fraternity, the doctors, the nurses, and the nurses, as well as allied health specialties who work in neonates who are asked the questions. And you can see all the different things which people have come up with. But in essence, you can see that treatment does not lead to meaningful life, and treatment will not prevent death is what a considerable number of respondents have said. Finally, you can see that conflict between medical team and family was also the definition given by two of them. So the debate of futility had started way back from the time of Hippocrates. There has always been a discussion of what exactly is futility, and the debate still continues. So in a sense, medical futility, if you go by the standard definition, is that treatment which does not improve quality of life, does not improve the outcome, or treatment which prolongs suffering is, in essence, medical futility. A treatment that has its sole purpose is the physiological extension or prolonging of life is also considered futile. So the futility can be subdivided into further categories. So the first one is physiological futility. Treatment does not provide the physical or medical benefit to the patient. So this basically focuses on achieving physiological effects. The examples are if you give antibiotics to treat viral infections, there is absolute physiological futility. There is no point in giving CPR in a patient with cardiac rupture. Now, this says that the intended physiological effect doesn't happen in that particular intervention. So that is what is known as physiological futility. Then you have quantitative futility. That is, the chance of producing the desired effect is extremely low, less than 1%. So in essence, if you have had previous 100 cases and you have tried an intervention and it has worked only in one case, then that means that it is a quantitative futility, or the process is a quantitative futility. For example, resuscitating a 21-weeker, which would not generally happen. If it would have happened successfully or maybe unsuccessfully in less than one case, less than a few cases. Qualitative futility. So that here the treatments having desired physiological effects but are worthless to the patient. For example, resuscitating a patient who is in permanent vegetative state. The treatment has no value on the patient's quality of life, irrespective of whether you resuscitate a patient who is in permanent vegetative state. He's going to continue in a permanent vegetative state. His quality of life is not going to improve. So this is what is known as qualitative futility. And this has a wide-bearing impact on most of the decisions we make as neonatologists and pediatricians in our units. Then there is imminent demise futility. So treatment given to a patient who is to die in the very near future. Example, renal dialysis in a patient with multi-organ dysfunction. Even if you give renal dialysis in this patient, he has multi-organ dysfunction syndrome. And it is not going to help the patient have a better quality in that sense. Lethal condition futility. So irrespective of treatment, patient will die in the near future, maybe in the next couple of weeks or couple of days or a couple of hours. So say successful CPR in a terminal patient who will die irrespective in the near future. For example, a pancreatic cancer patient is not going to live for quite some time, even if we do a successful CPR, because the prognostication is very poor. So in essence, these 5 subdivisions of futility is what make people decide on what the end of life care will be. The decisions are slightly different in different countries, but in essence, they're mostly the same. The other thing is limiting life-sustaining treatment. So what are life-sustaining treatments? Giving anatropes, continuing ventilation in a patient to see how long he goes on. So what does the RCP say? When can we limit such life-sustaining treatment? So our body, the Royal College of Pediatrics and Child Health, has set out 3 conditions. So when life is limited in quantity, that is, the patient is not going to live for some time more, or when life is limited in quality, the burden of the disease itself is not going to let the child have a good quality of life. And then there is, in the pediatric patients, informed competent refusal of treatment, where the slightly older patient can actually have a competent refusal of treatment. So these are 3 situations which RCPCH says that you can limit life-sustaining treatments. Now, withholding versus withdrawing, are they the same? I'll give you 5 seconds to think about it. Are they the same? Are they legally same? Are they ethically the same? What do you feel? Have a think about it, and then we can come back to it in the question and answer session.
So Jasim, just a few questions that have cropped up about the case. So clearly we had a baby at 26 weeks of gestation.
Yep.
I mean, ventilator dependent at 44 weeks, steroids, sildenafil. You've treated for infection. I mean, looks as if you've reversed all causes. So I've got a question from Linda.
Yeah.
And so she's a nurse, and she's basically asked, so she would worry about the patient suffering at this particular stage, and the best interests of the child would have to be paramount. So I mean, just in that particular perspective, if we continue conversations with the parents, isn't the child suffering?
The child is suffering.
So I mean, from your perspective, how did you approach that?
So, look, I'll come to that. I'll take that. I have the answer to the approach at the end of this.
Okay, that's
It
fine.
comes. I held it off so that people understand what is futility, what is withholding, withdrawing, before I go on to how we approach the case and how we should approach the case, such cases in future as well. So, shall I take that? Shall I go through the slides and then
Yeah,
most likely
go through the slides and then, yeah.
she'll get the answer to that. Is there any other question which you want me to take now?
So there's just, no, I think there's Samir from India who's said that at 40 weeks, another course of steroids wouldn't be unreasonable.
Yeah. So again, that is there at the end of the slides. Yeah. I brought the topics up so that it is there as a background, the case. And then I'm going through the basics of things like futility and withholding versus withdrawing, life-sustaining treatment, so people understand that. And then I go back to the case at the end of the slides. So you'll have the answers to those questions at the end. Is that okay?
Yes, fine. Absolutely fine.
Yeah. So withholding versus withdrawing. Are they the same? They are ethically, yes. Legally, they are the same, yes. But then as medical professionals, do we feel that withholding versus withdrawing is the same? Are you comfortable withholding, for instance, clinically assisted nutrition in a patient? Or are you comfortable not escalating care, but you don't want to take out the tube in a patient as medical professionals? So I will get to the answer of that, but I'll just talk about the doctrine of double effect as well. So what is the doctrine of double effects? It allows treatment to be given to alleviate painful and distressing symptoms, even if it is foreseen that the treatment may hasten death. So how do you do it? The act itself must be morally good or at least indifferent. So the intention must be to cause the good effect, that is patient comfort. The bad effect, example, hastening of death, can be foreseen, but there must be no other way to achieve the good effect. So this is like giving sedatives to keep the patient comfortable, or giving pain medications to keep the patient comfortable. Is at times it can hasten death, but then your intention is good. You're trying to cause the good effect, which is patient comfort, but there might be a bad effect, but overall, it is good. The bad effect must not be the means of producing the good effect. So you should not try to hasten death by trying to alleviate pain as well. So it is not permissible to use a bad means to a good end. And the good effect must be sufficiently desirable to compensate for allowing of the bad effect. Yeah. So to alleviating pain in this particular our scenario is almost always sufficiently desirable. So that is the doctrine of double effect. So in essence, if somebody asks you, you're giving morphine to my patient, is it okay? Then it, based on the doctrine of double effect, which has come from the teachings of ages, is okay. So religion, what does religion play in our society? I would call it not just religion, but belief in essence. Religion has different connotations. There are the big Abrahamic religions which are there in our society, which most people know and everybody is aware of. Then there are a lot of other religions which people and practices which people might not be aware of. Say in a multicultural city like the UK or cities in the UK, people will be aware of a few religions, but then you might have certain religions which are belonging to smaller sects, which people might not be aware of their practices. And different religions have different connotations, and the way they infer and interact are slightly different to each other. So the whole basis of religious concept comes from the concept of sanctity of life. Every life is precious, and I think that that is mentioned in almost every scripture. But then whether the life is precious and should we prolong the life just because it is precious is the big question. So should we move towards sanctity of life or quality of life are different in different religious contexts. If you take say the Catholics, I'll come to that, or the Orthodox Jewish system, they wouldn't want withdrawal of care, the Orthodox Jews. Whereas if you take the Hindu scriptures, or if you take the Sikhs, for instance, They believe in reincarnation and karma. And for them, you are always reincarnated, and they would not want to prolong or hasten suffering, uh, and would allow withdrawal of care. So that people adhere to religious scripture. Now, the issue with religious scriptures are that you have different connotations of religious scriptures by people of the same religion. You'll have, take Christianity for instance. You have the Protestants, you have uh, the Catholics, and again the Catholics are, you have the Roman Catholics, you have the Latin Catholics, you have the evangelical Christians, and the connotations of the scripture are inferred by people in slightly different modes of the same religion itself. And their perspective to end of life care might change from what is the perspective. So one Christian's perspective might not be another Christian's perspective. The same applies to Islam. You have the Shias, you have the Sunnis, and also the scripture. You have the Quran. If the Quran doesn't state that, then you have the Sunnahs, and if the Sunnahs doesn't state that, then you go on to learned religious people, and then if you don't go, you go on to the fiqh. So there are different modes which you can use, but in essence, the interpretation of the scripture are different among different sects of each of the same religion. So that kind of brings a different connotation to end of life care. Uh, and again, there is religious ostracization. If you belong to a particular community, and you and the religious scripture say doesn't allow withdrawal of care, and you ultimately end up withdrawing care, you might not be then welcomed back into the community you are a part of. So that it might not be that the religion is the actual, your religious belief might not be the actual reason for you not allowing withdrawal of care. It might be just that you're worried that what will your imam think of you when you go back to your community place of worship. So all these are different connotations which we have seen at different parts in different patient scenarios at different points of time. So let's look at physicians' attitudes and relationship with self-reported practices in 10 European countries. This came out in JAMA in 2007, slightly old paper, but again, very relevant. And if you look at it, this is from the Euronic study, and the same group of patients were used, the group of participants were used from the Euronic study. And if you look at these countries here, so a lower score essentially means that you have a pro-life attitude, a life as in prolonging life irrespective of quality of life, whereas a high score, you have a more quality of life attitude or a QOL attitude. So you can see that the Netherlands, the United Kingdom, and Sweden score slightly higher, say compared to Estonia or Lithuania, the Eastern European countries, and Spain and Italy are somewhere in the middle. So that's how the Europeans think. What about the Asians? So this came about, this is in the adult intensive care units in Asia. This is a survey sent out to almost 2,000 participants, asking them about what they think about withholding and withdrawal of life-sustaining treatments in intensive care units in Asia. And you can see that 74.5% deemed withholding and withdrawal were ethically different. They have done withholding and withdrawing at certain points of time, and this is what how they have responded. So you can see that a huge number of people actually think that withholding and withdrawing are ethically different and legally different. The same applies to lots of other studies. If you take an average of all the studies which have looked at what are people comfortable with withholding or withdrawing, see that 12 to 50% of people are more comfortable with withholding than with withdrawal. This was a paper which came out from Homerton in London. Again, a slightly old paper, but they looked at a huge number of patients who had passed away over a couple of decades. And they looked at this slide actually shows the ethnicity and parents agreeing to or refusing withdrawal of life-sustaining treatment. And you can see that the whites generally agreed to withdrawal, and the you see only 2 patients out of the whole number did not agree, whereas Black Africans were somewhere in the middle. 7 of them agreed, 6 of them refused. Afro-Caribbeans, more of them agreed. Among the Jewish, you have more Jewish people who refused, though the number is small. And the Indian subcontinent generally agreed. So that it's an interesting slide because the ethnicity also shows how you take decisions. I think the Homerton didn't actually go subdivide them into their religions because the number was small. Now, what are the religious views on the end of life care? This is again from an adult paper, but if Catholics, they are okay for withholding, yes, they're okay for withdrawal, they're okay for doctrine of double effect as well, but no euthanasia. If you look at Protestants, again, they're okay for withholding and withdrawal and for double effect. And some Protestants are okay with euthanasia. The Greek Orthodox, they would not withhold care, they would not withdraw care, and they would not agree for the doctrine of double effect as well. That is, give sedations for reduction of pain or paralytics to help. And they are not for euthanasia as well. Muslims, they are okay for withholding and withdrawal of care, and okay with double effect, doctrine of double effect as well, but again, no to euthanasia. The Orthodox Jews, they are okay with withholding, but no to withdrawal. Again, comes from the principle of the gauses, that the life that you are still alive when you have imminent death, which is near, but they are okay with the doctrine of double effect, and there is alleviation of pain is allowed even if unintentionally it hastens death, which I had spoken about before in the previous slide. Again, everybody is almost no to euthanasia. The New Zealand thinks differently. I'm sure you would have heard about New Zealand in the news with respect to euthanasia. So I'm coming back to the questions, Alok, and let's discuss patient X again. So how would you approach the case? And how would you establish futility? So I think from the background of the case, at 44 weeks, discussions with parents were initiated, high ventilation settings, and there was nothing much to offer. There was clinical and both medical and nursing consensus that there was nothing else to offer here. Parents want to continue all intensive care based on religious learnings. And there was clinical consensus that the patient is in distress, the baby is suffering, and we need to do something. So how did we go about, or how do you go about such scenarios? So first is you try to establish futility. So a third course of steroids were given, a repeat dose of surfactant was given, inhaled steroids were tried, nothing worked. So then you sat down with the parents. The approach, you make a shared care decision model, and you give them an informed choice. You sit down with them, you tell them about all the things which we have done, all the things which can be done in the future, which is essentially not too much, and you offer redirection of care. But there was disagreement. Then you go on to mediation or further treatment on demonstrating futility. So further treatment on demonstrating futility was tried. Third course of steroids were tried. Patient didn't, the oxygen requirement didn't come down. The best interest principles were spoken about. That is, we have to work towards the best, in the best interest of the child. And over here, we, as a medical team, were feeling that the patient is suffering, but there was disagreement. And that's when what do you do next? You can offer a second opinion. Now, in such scenarios where we personally look after such patients, we have the 2 things to a second opinion. So recently I had a case which was a metabolic disease, which we had the neurologist, the respiratory physician, that is a specialty respiratory physician, the specialty neurologist, who are based in a hospital, in another hospital, already involved. So then the question came, aren't they already second opinions? Are they not specialist opinions? So when we put that to our legal team, they told that since they are already are attached to the specialty team of the hospital, though they are from another trust, they don't legally hold the standpoint of a second opinion. So you have to take a second opinion from an independent trust, and it should be a neonatologist. If you're a neonatal practitioner, and if you're looking at neonatal death, it has to be a neonatologist, is what the legal opinion was given to us. So you have to take a second opinion from somebody from another trust, and you can also give the parents the option that they can bring in somebody for a second opinion as well. They can bring in their nominated neonatal consultant for a second opinion. Just before that, mediation. Mediation, there are experts in mediation, at least in the UK, who help with such kind of disagreements, and who come in and from a uh, independent standpoint sit down with both the parents and the medical team and try to mediate and go through the problem, and see if the parents agree to the scenario. If that doesn't work, then you go into a second opinion. A mediation can happen before the second opinion or after the second opinion as well. It can be tried again. If that doesn't happen, then we go through the ethics panel, uh, and the you also have the ethics committees. Again, in this country, you have many ethics committees, but at times you might not be able to reach them as well. So that is also a problem. But there is a possibility that you can talk to the ethics committee, either in hospital ethics committee. Most hospitals might not have in hospital ethics committee, but there are ethics committees formed who you can approach and ask for help. And if nothing else works, then you go the legal recourse. So you, like I said, you give a shared care decision making model. You offer redirection of care. There is disagreement. You go into mediation. You talk about best interest principle. Again, there is disagreement. Uh, and at that point of time, you try to find the frame of why this is happening. The more you talk to the parents, the more you are in such scenarios. It might not be that religion per se is what is making, in this particular case, it was not religion that was particularly making the scenario. Religion was there as an aspect, but in this particular scenario, it was more of ostracization in the community. The father had the strong feeling that how could he go back to his community if he does this? For instance, a person of a particular religion might behave differently, or might think differently, or have different beliefs with another person of the same religion as well. If you take my example, for instance, from where I come from in India. I'm a Muslim by birth, but where I come from, my wife or my parents don't wear the hijab, or don't cover their don't put a covering on their hair. But if you move, say, 250 miles away from where I come from, where my wife's family is, though my wife doesn't wear it, my wife's relatives, most of them, they wear the hijab. So it's the same religion can have different connotations. uh, the so we go on to the second opinion, and if nothing else works, we go to court. So parental views, respect them, acknowledge their views, and try to support them. That's all we can do as medical professionals, and try to alleviate suffering for the baby, as well as keeping the parents supported. Always try to find the frame. There's the fear of death of the baby, the fear of social ostracism, the fear of law, and then conviction as well. Again, remember, religion might be something else. Involving faith leaders and medical staff of that faith might help, but it can hinder as well. So you don't know how things will pan out if you involve faith leaders. But there are times when you have a particular sect and you don't have a hospital chaplain or a hospital imam, or if say they're of a different religion, it might help at times to bring in their own religious leader to the discussion and see how things go. But it's like a double-edged sword. So what we have done in our setup, and this has come up very recently, we've worked on this for quite some time, but what we do now is we have a complex care team concept, which are led by consultants. So we have, in general, we have a hot week consultant who's the ITU in charge, and he takes care of day-to-day care, and he takes care of all the parental discussions, all the complex problems which occurs. But we also have a named consultant of this patient who will come in and have weekly discussions with the parents. The parents have a sort of continuity of care because the hot week consultant changes every week, and we have 1 and 8 hot weeks. So I come back in 8 weeks time after I finish my hot week. So and then don't see the parent and come back after 8 weeks. So there might not be continuity of one consultant talking to the parents. So we have kind of changed that up, and we've got the name consultant having weekly discussions with the parents. Now, we are a non-surgical unit, so we mainly, our core patient load are the pretermers, the 23 and now the 22 weekers as well. So what we have now is we have a long-term respiratory ventilation lead with special interest in that. And if the moment the patient touches 36 weeks, he comes into the picture as well. And his main core job role is to create respiratory ventilation plans, liaison with the respiratory physician, and see if for complex patients, and see if there is if this patient will need long-term ventilation, how we go about optimizing ventilation, sedation. He kind of comes with an overview of the respiratory care, and then we have the ethical lead, which is my role. And I deal with the moral distress. So it doesn't matter if it's a 36 week or below, but if there is any moral distress, be it staff conflict with respect to a patient, that is what I meant, a nurse or a consultant conflict, or again conflict with respect to withdrawal, conflict resolution, getting mediation in play, and then looking at and talking to the legal team. All that falls under my job role now. So, and then we have a palliative lead. If a patient needs palliation, or if we don't have complex problems, or if we have had complex problems that we have resolved, then the palliative and the bereavement lead consultant comes into play, and they take over with respect to palliation. We have things in place for the protocols in place for that, and each of us have a nursing lead as well. That is, the hot week consultant will have the day-to-day nursing in charges. The name consultant will not have a nursing lead. He just comes and has discussions with whoever is the nurse who's looking after the patient at that time. But there's a respiratory and ventilation long-term lead nurse who takes part in the discussions. There's an ethical lead nurse as well who helps with the ethical discussions as well as talking to the nursing team. And we have a palliative need. And each of these, there are a team of nurses for each of these sections with one nursing lead. The thing which we have found useful is that whenever there's a problem, somebody just helps and comes in there, and everybody's aware of things. We have seen that a lot of moral distress among the staff has reduced, mainly because every time there's a distress, there's a go-to person who will be the complex care team, say ethical nursing lead. If there's a nursing issue or if there's a consultant issue, they come to me, and once the nursing issue is addressed, they come to it comes to us, and then we take it back to the consultant and have a discussion as well. We also have an ethical framework in these complex care patients. Once they cross 36 weeks, we have a format which we use to sit down and then discuss these patients in detail, and see if anything else is required. So that's what we have developed, this complex care team concept recently, and this has been helping us. So I thought I'll share this with you as well. That's it. Thank you. Alok.
Yeah, Jasim, thank you for a fantastic talk. I think that was absolutely amazing. We've got quite a few questions. I'm going to start with our YouTube participants first. So we have a question from a colleague working in Myanmar. So Sufi is her name.
Yep.
And what she said is that clearly in their setup, the parents would not be the decision makers. So how does that work in the UK? Because technically, it must be a lot of pressure to put the parents in a situation of having to decide whether their child should die or live.
Yeah.
So why is that the case in the UK?
I think it's more of a joint decision here. It's the medical team comes up with what exactly is the best in the best interest of the child, and talks to the parents and tell them that this is what is the scenario is, and this is what we think about the long-term prognosis of this particular condition, and then we don't leave it to the parents to exclusively decide that they would, okay. We always tell them that it's a joint discussion and it's a joint decision. They are not making the sole decision of withdrawal of care. Though it looks like the parents have to take the final decision, it is more of a joint decision which happens in the UK.
Okay, so we have a question from Linda. So one of the questions obviously is with regards to the case, and her anxiety is, do we give the parents' considerations and thoughts and views too much weight? Are we doing that in the case that you've mentioned? And how do we address that? Because how do we weigh up the balance of best interests of that child versus the fact that, the parents might be confounding the issue?
I think with that particular case, the parents were given all recourses to understand what is going on. The scenario was that the parents wanted all-out care. They felt that the miracle will happen, and we just had to talk to them at multiple points of time. The problem with going through the legal recourse or going through the process is that each of these processes take time. It can't be a 1 day, 2 day decision, and we have to give them time to come back to us. I've had parents who have said, yes, we can withdraw tomorrow. I want to show my mother the baby. So they bring their grandmother. I'm talking about a COVID scenario where you're not allowed to bring in other relatives to see, or other visitors are not allowed. And then they bring in their grandmother, the baby's grandmother shows the baby. And then in the evening, we come back and say that, sorry, we want to continue all out care. So these things take time. While this is happening, we try to ensure that the baby is in the best comfortable state possible. Does that answer the question?
Yeah, it does. I was just going to add that one of the approaches that we've used in our setup in situations like that is we might speak to the parents and agree a ceiling of care. And sometimes, that there's that thought of, well, we need to treat and do everything. But the question is, in the context of that child, what everything might mean for the parents. And we've sometimes in those situations kind of agreed a ceiling of, well, we might not necessarily, if there is a loss of heartbeat, say, for example, do compressions or give adrenaline. Alternatively, it might be, well, oxygen is not having any effect. And actually, if the baby were to desaturate at this particular point, it might be that ceiling at 100%, well, we will not give nitric in that particular situation because it's not worked in the past, or because we think overall it will not improve the actual state or clinical state of the child. So there's a question from Samir, and again, I think it comes back to the question that a colleague from Myanmar asked, and he talked about the fact that would you need parental consent to stop life-sustaining intensive care in the UK? Would you be able to stop without the parents agreeing?
You'll have to go to court, and get the court's approval before you withhold care if the parents don't agree.
Okay.
Yep.
So I'm going to open the floor up to my colleagues. So I've got Leva, Anna, and Gautam online. So I was just going to ask them whether they have any questions they would like to ask you.
Yeah, look, I can only see 5 videos or something out here, so I'm not very sure how.
Leva, do you want to go first?
Thank you for this very interesting talk. I haven't got any specific questions at the moment, but I'm very interested that you developed this complex care pathway, because I think by having that, you might be able to resolve a lot of conflict situations before they actually arise properly. So really good work on that. Thank you.
Thank you. Thank you.
So I'm going to put a question out to everybody. So in situations where we've had to go to court, at least in the UK, does anybody have an idea about what the outcomes have been so far? A rough guesstimate. So if we took 10 cases to court, how many cases has the court agreed with the medical teams that actually stopping life-sustaining intensive care is in the best interests of the child? So Anna's basically said, I guess it would be the majority. So just to give you an idea, up till the case of baby Begum, who is the Bangladeshi baby who had intracranial hemorrhage and seizures and was admitted to a London hospital, all cases that went to court where there was disagreement on religious grounds, where parents wanted to carry on life-sustaining intensive care, were decided in favor of the medical teams. So, until that particular case, we were in a situation where, I think courts more or less agreed and worked on the grounds that the best interests of the child take primacy, and that if we can demonstrate a reasonable component of suffering that this child is going to get or go through, with the potential for not having an outcome that either provides sustainable life or a quality of life, or where we have been able to define futility because there's no other treatment that's available, then in those situations the court has favored medical teams. But it's very interesting that in the case of baby Begum, the court actually decided to support the parental views, and the grounds for that were so when that case went to court again, the parents had very strong convictions that they felt that there was further treatment that was available that could be given to their baby, and that could be provided, and that was being provided in a hospital in Italy. So they could actually take the baby to Italy, get that treatment, and in their views that would offer the child treatment that would be sufficient to produce an outcome which would provide a quality of life which they felt was acceptable to them in the long term. The hospital decided that actually they would contest this. And the reason they wanted to contest this is because they were mainly worried about the fact that actually treatment to provide life-sustaining intensive care at that particular point had reached a ceiling. And that further treatment that would be provided in Italy would not necessarily actually change the outcome. And interestingly, the judge actually felt that at this particular point, baby Begum was not suffering. So was not suffering and was in a situation where that treatment with the uncertainty may or may not provide a quality of life. Hence, it should be tried. And I think the biggest argument then that was put forward in subsequent hearings were about transport and the suffering that the child might have while being transported. And I think having taken all those views into account, a plan was subsequently made and the baby was transferred to Italy for further management. I think the message that I would give to you, and I'll bring Jasim in on this as well because he wants to say something, is that it is very important from our perspective that we have gone through the process of trying to demonstrate futility very objectively, and that we're in a situation where we can demonstrate suffering objectively as well. Because actually what the court wants to know in these situations is, well, is the child suffering, but also are there treatments that are available that at this particular point can alleviate that suffering? And is there treatment that is potentially then available that may result in an outcome with a quality of life that might be acceptable to the parents? Jasim, you were going to come in.
I think in that particular case, this is Tawfiq or Rafiq, there was the add-on that the parents brought in the argument that if this child being of Bangladeshi origin, if this child was in Bangladesh and if they wanted to actually move for another treatment, they would be allowed to go, considering that the child would have been brought up in that situation And in that scenario, that was one of the arguments, I think, which helped them win as well. And they also had a ruling from EHRC, from the European Human Rights Group, which also said that that the child should have further treatment to go on. I think those things tipped the favor towards the parents in that particular case. Just to add a look.
Yeah. That's really helpful, Jasim. I think I'd also want to thank Jasim for providing us the approach. And the reason I would want to highlight that is I can't emphasize enough how when we as clinicians come into conversations, we look at the parents' values and religion sometimes and take it for granted and assume that actually they are refusing because religion says so. But actually there might be reasons other than that. In particular, the worry that they might be socially ostracized if they agree with that decision. There might be reasons which we need to explore. And a very important one, say I'm a Hindu and I come from a Hindu background, is society in my setup is quite patriarchal. And actually a lot of us want to protect our better halves, our wives, from having to make decisions like that. So actually by keeping the baby alive, we are in a way protecting our wives from having to go through the grief of having lost their child. If the child were to die on the ventilator, then that would be the child making the decision rather than us having to make that decision. And again, it's less about religion. It's more about the belief that we have at that particular point of time. And if you can tease that out and bring comfort into the fact that actually the mother and both you would be able to have quality time with the baby, and that's not actually stopping care. We're not stopping care. We're continuing to care. We're just caring in a very different way. And actually, it does not actually sit against your religious beliefs. I think that's where bringing in somebody from the family sometimes also helps. And I've been in a situation with a Kurdish family where that was exactly the case. The father's main concern was that the mother should not be subject to any kind of such decision-making because of the guilt that she would have to live with and he would have to live with, as opposed to religion being the primary driver. We were able to get an imam of their religious sect. And just to give you an idea of how difficult that was, their imam from their sect was in Birmingham and was the only imam like that in the entire country. And we had to speak to him and organize for him to come on a particular day to speak to the parents. And actually what he did was he reassured them that actually what they would be doing at this particular stage was perfectly legitimate. And actually that, it would not be in violation of their religion at that particular point of time. But I think what was very striking for us was the fact that actually that's what the mother wanted. She wanted to let go. But because of culture and religion, it was very difficult for her to speak up in that environment. And I think the overall feeling that we got once we were able to reach that point was I sensed a lot of relief in that family for us being able to take that approach, because they then felt that actually the decision could be made, the child could be allowed, to go on a journey that's slightly different to what they had planned, and they could do it without guilt because actually their religious leader had actually supported them in that decision making. So again, I would really say, talk to those families, speak to them about their circumstances, look at the personal values that they have, acknowledge them, respect them. And then the question from your perspective is how you might be able to shepherd them into a decision that they may not be making because of their religion, but because of their actual culture and circumstances. Jasim, anything else you'd like to say?
Just to add to that, I've recently had interactions with one of the parents who, when we talked about getting the imam in our hospital religious leader in, he refused, and then we asked him whether he could get his own, if in confidence with his own imam or religious leader. He said that is not necessary. That is not what he's basing his decision on. So you will have people of a certain religion, but they might not be religious. Might need to be aware of that as well. So And another interesting point is that the big religions, that is the Abrahamic religions, essentially are known and are understood, and people kind of agree to their practices. For instance, circumcision is accepted, and people actually they don't say no to circumcision. But if you have a smaller religion having a particular, say, like piercing by day 8 of life, which is not acceptable, because these are smaller religions. So there's this kind of the big and small religions interplay as well. So these are things which you need to keep in mind and be culturally aware when you sit down and have conversations with parents.
I am going to take this opportunity to thank Jasim for what has been an excellent session. I think the approach that you brought forward, Jasim, is something that I would, with your permission, I really want to share with my colleagues over here,
Sure.
because I think there's something to say about continuity of care that you might encounter by having a lead clinician and a lead nurse who can advocate for the parents in such circumstances, because they might feel alienated by speaking to the same consultant and the same team. Thank you everyone for coming. I'm really grateful, and I look forward to seeing you for the next one. Thank you.
Thank you, Alok. Thank you. Thank you all. Hope you had a good session. Bye.